So our panel up here, let's start at the far end. I'll just remind you of everybody who spoke earlier so you remember their topics. Dr. Enos is on the end, the naturopath. Next to her is Dr. Maril, who presented in one of the breakout sessions. She is a psychologist and did the session on caregivers. Next to her is Amy. Couldn't tell if there was anybody in between you. Amy Johnson is a scleroderma patient. Next to her is Dr. Moore, who talked a little bit about the pediatric, again, juvenile clinical trials this morning. And she is the rheumatologist on the board because all our others had to take off today. So thank you for coming back. And then beside her is Lauren and Jason Higbee. Lauren has scleroderma, and Jason is her caregiver. I don't know, Lauren's pretty strong-willed if she lets Jason be a caregiver. So we have Gloria in the back. If you do have a question, please raise your hand. We're recording this session, so to make sure that all the questions get picked up as well as the answers, Gloria will come to you with the microphone, and also remind our panel to please repeat the question and also use a microphone. We've got a few that we'll pass around. Okay, go for it. Okay, why don't we have Amy and Lauren, why don't you tell us a little bit about yourselves first and your journey with scleroderma.
Sure, I'll go first. My name is Lauren Higbee. I have had scleroderma for about 16 years, maybe a little bit more. I'm 32 now. I was diagnosed at 21, but I started having symptoms when I was probably about 13, 14. So started off with heartburn when I was about 13 years old. I was an active, healthy person with chronic heartburn, and people just put me, or said, "Here, take this PPI." So I've been on PPIs for 17, 18 years or so now. Next came the Raynaud's, and I was at ski club, and I thought it was cool how my hands changed colors, and thought that was pretty cool, and then had no idea what it was. So then probably about 17, 18, more symptoms started coming on. ANA positive, went to a rheumatologist. They still had no idea. So I say probably about 5 or 6 years I was going to doctors trying to figure out what was wrong with me. But it took until I was about 21 years old to have a GI doctor actually say, what are those little red dots on your face? Those are telangiectasias, and ask me about some other symptoms. And it's like, oh, you have scleroderma. So I'm 21 years old, and I finally graduated college. I'm in the workforce for the first time, and, starting my life as an adult. And then I'm doing research, and I'm finding that, I have 5 to 15 years to live. Well, here I am 15 years later, perfectly fine. I'm, doing good. So I think my biggest thing has been to not listen to the statistics and not really, go online and do all that research. It's more about taking care of myself personally and taking care of my symptoms and not thinking about those statistics and things like that. But yeah, I still take care of myself pretty good. I go to doctors twice a year or so. I found really good ones because for a while I had bad doctors. Not bad doctors, I should never say that. Doctors that weren't informed. So who were wanting to put me on medications that I should have never been on, and just not the right type of care. But after really, doing my own research and figuring out what's best for me, it's really helped me thrive where I am now. So, yeah, I can ramble on forever, but that's a little bit about myself. And then here's Amy.
Hi there, my name is Amy Johnson, and I also have scleroderma. I was diagnosed in September of 2013, and was able to attend my first support group in October of 2013, and found out a lot of information about scleroderma at the patient education day, which was great information. It let me have some hope as to what was ahead of me. I was diagnosed with diffuse scleroderma, which, like Lauren was saying, you read on the internet, the life expectancy is not very good. It's usually 5 to 7 years is what you tend to read. I was lucky enough also to have good doctors who were able to diagnose me pretty quick. My first symptoms were actually in 2012, and for me, my symptoms were the heartburn. I had puffy hands, Raynaud's, and then just the gastrointestinal system just wasn't working like it normally should. Had a lot of swelling, and just was overall fatigued all the time. After trying various treatments to help stop the progression of my disease, I opted to go get a stem cell transplant in Chicago, and I had that done last year, so I'm 1 year post-transplant, and so far things seem to be getting better. I've gotten my energy back, my skin's loosened up a little bit, and the Raynaud's is still the same. I have really bad Raynaud's, and the GI still isn't the best, but I can say that my energy is much, much better, and I just feel overall quite a bit better since the transplant, and that's about it about me.
Questions? Is everybody tired, or is everybody catching the last few minutes of football games? Annette?
Is there any eye issues that people are experiencing with the condition? I have extreme dry eye. I have multiple eye issues anyway, but that could be independent of scleroderma. But I've read that dry eye can be interrelated to autoimmune, so just a question.
I could kind of answer to that a little bit. I've had dry eyes for a very, very long time, and they had no idea what it was until probably 10 years after they finally made the correlation. But I had tear duct plugs put in when I was probably about 15 years old, which, again, was just weird that my eyes would be so dry without any other explanation. But, yeah, so I've always experienced that, the dry, itchy eyes. So I don't know if that's like a symptom that they look for when they're diagnosing scleroderma, but I would say it's probably pretty common. And I don't know if you've had the tear duct plugs put in. Yeah, mine fell out. So it helped for a while when I had them, but yeah, so I've noticed that as well. But.
There we go. Oh yeah, there. Usually it's more of a nuisance factor, but definitely, I mean, if it's severe, irritation to the eye can be somewhat damaging, just, to the outer surface of the eye with ulcerations on the eye itself. That's not super common by any means, but is potential. But the biggest thing is just quality of life and comfort, and often things like artificial tears as well as the tear duct plugs can be helpful. There's a medication called Plaquenil that also sometimes is very helpful for, especially when you do have those overlap conditions where you get kind of scleroderma plus features of other autoimmune conditions, and some people have found that to be helpful for the dry eye component as well. Plaquenil has a weird story. It started life as an anti-malaria medicine. It still is. It's just not a phenomenal anti-malaria medicine. But they realized that the folks who went on it for malaria treatment who had illnesses like lupus and rheumatoid arthritis had improvement in their symptoms. So they started studying it more, and we found that it actually has a lot of kind of immune modulating properties and anti-inflammatory properties to it as well.
This one's for Jason.
Ready.
So what is the one thing as a caregiver / partner that you think you do for Lauren that is most beneficial?
That's a good one. Well, first and foremost, I had to do a lot of learning, to even understand kind of what scleroderma was. Probably like many people, when you first hear the word, you don't quite understand it. So kind of understanding what the disease is helps me kind of have some empathy for Lauren, and we can kind of approach her disease kind of as a team that way. I feel like my number one job is to kind of try to empower her to, live the type of lifestyle that she wants to live, that we both want to live, and then help her like by supporting her to do that. So it was an evolution for me trying to understand kind of what is scleroderma, kind of what are some of the limitations, and that was very eye-opening because there is no right answer to that question. It's mainly figuring out how scleroderma presents in you. So over our time together, we kind of work around some of the limitations with Lauren, and have, we try to make it scleroderma an inconvenience in our life, but not like an impossibility in our life. So a lot of times when we have plans, we want to, live those type of dreams and plans together, but we try to figure out how to incorporate scleroderma in that. So
Like how you can go to Iceland for 2 weeks with this.
yeah, we just got back from Iceland. So I think the word stubborn came up earlier, and that's kind of how I viewed Lauren a lot with it, is stubborn. She doesn't want to admit no. She doesn't want to admit she has limitations. Over time, I've kind of seen her. It's not stubborn. It's determination is really how I view it. She's determined to not let it hold her back. So that's really what I have taken from my time so far with her and the disease. Try to manage it, try to live with it, but don't let it be an anchor, so to speak. So I hope I'm doing that. But yeah, just support and empower really is kind of how I've approached it so far, because for me, she's lived with it half her life. For me, it's 5 years. So
Good job. You're doing good.
I'm trying.
This would be for Lauren. Is that your name? What kind of limitations did you start noticing for your husband or whatever he is? What did you notice that you couldn't do, that you had to admit, I need to give these things up? I'm talking about housekeeping, shopping, whatever. You just tell me.
All of that. So mainly I'd say anything that involves my hands. So, the strength in our hands is not the same as anyone else. We can't grip things the way most people can. So I would say that would be the first thing. And I think the stubbornness comes from, he watches me try to do it by myself so many times before I finally just hand it over and say, do it. But also just, going out and doing things that other people would do without problems. It could be in the summer, but I still need to be fully bundled up because it's going to, nighttime's going to come and it's going to get cold, even though for most people 70 degrees isn't cold. For me, yeah, it's cold. So just always having like a winter coat, gloves, and hat in the summer, those kind of things. Yeah. Oh, limitations also with the cleaning. That's been a big thing. Using chemicals can be really harsh on our hands. So just modifying that, not using those types. I've changed all types of chemicals in my house. I do not use any type of harsh chemicals or anything because not only do they trigger Raynaud's, but they're bad for our skin and other things. So yeah, I don't know. Am I answering your question? Okay.
I can add some to that too. I mean, Lauren's a very active person. She likes to work out, once a day if she can type stuff. And one of the things that we started doing that I've noticed that there's some limitations was hiking. We like to go camping. We like to go hiking. We like to enjoy nature. And it's very, very impossible in Colorado to predict nature here. So one thing that we've tried to get ahead of a lot of that, I think we're getting really good at now, is just trying to be prepared for a lot of those situations. Like she said, bundling up stuff, but having hand warmers, either, those packets, or gloves, or hats, or, having someone to, I try to help her, remind her of that, but, we'll just be prepared for a lot of those things because the symptoms just present so fast sometimes. And I think she's done a really good job with hiking and things like that. Just getting it, maybe recognizing that she can't necessarily climb a 14er as fast as she wants to, but not really being discouraged by that, still achieving that. And, maybe, I don't know, you can speak to that if you have different goals or different thresholds in your physical exertion that you've seen go off, but that's kind of, it doesn't really hold her back so much as just it gets managed differently, so.
So I have a question, kind of an extension of that, with the limitations, and also Dr. Maril can maybe expand on this too. As a caregiver, how do you help her recognize when she's at her limit? I know if someone were to tell me, you've done enough, stop, I do just the opposite. So how have you learned to communicate, or how do you help her with that?
I'm going to speak first for him. No, well, usually he's doing the thinking for me before I do. He's planning before me, which helps because then I get to focus on the end goal because he's like got my back, So he's the one planning in advance and thinking about all of the things before they happen. Here now you.
Well, that's kind of what I was going to say anyway, was because Lauren, if we have a goal, she wants to achieve that goal or experience or just do something. I'm kind of more of the, I don't get as stressed as much. I'm a little bit more even keel, so it might be easier for me to kind of process and see some of those things, those gotchas, so to speak. So I'll try to plan. I'll try to do my best, but it's a cooperative effort that we both, go on because I let her try to go as far as she can before she asks for help. I'm never going to really force anything on her. So I think we have a pretty good dynamic worked out, though, where she knows I'm there if she needs it. But she's super independent as well, and I think that's important, for her to have that ability to do whatever she wants with the tasks and the day-to-day and stuff like that. So obviously if something does fail, I'll be there to help her, but I think it's just getting that comfort level, to answer your question, is just, she's comfortable asking for help and I'm comfortable giving help. So in the beginning, it was more independent mode. Now we're approaching it more like a team, together. So
I've also become this is not even part of the question, but I've also become very comfortable with, if he's not around, asking a stranger for help. So if I'm at the grocery store, I don't care. Whoever's closest next to me, whether it's, grabbing into the freezer and grabbing something for me, I just ask. I don't explain why. I'm just like, hey, can you do this? Like, I see that they can do it perfectly fine. I have no shame in just asking for help when I know I need it. So there's, certain things I can be stubborn with, and then other things where I'm just like, nope, I'm not going to do that. I'm going to ask whoever it is around me for help, and people are really nice, so for the most part. But
if I can jump in a little bit, there's two things that I super love. Is that the good one? Okay. Well, if I hold it really still, I think we're good. Two things that I think are really cool is that y'all are recognizing that you're on the same team. You want the same goal. It's just how to get there. And sometimes in relationships, it can feel like we aren't on the same team with our partner, but we have to keep in mind, no, we want the same thing to happen. We just need to figure out how to get there. And then the second thing I think is really cool is that y'all are laughing about it. And that humor piece is so important to keep things a little bit lighter. It's different in relationships where one person is ill and then another person joins a relationship versus somebody gets a diagnosis during a relationship. When somebody gets a diagnosis during the relationship, that shifts things because you go from having two autonomous people to having an autonomous person and then someone who becomes more dependent. And independent people don't like to become dependent. That doesn't feel great. And the person who's not used to having to provide care, that causes strain too. So I think it's a little bit cliche maybe, but the communication has to be amped up even more. And, like you're saying, you kind of learn to read each other's thoughts. You anticipate what's going on, but you have to also be able to ask for what you need, which can be difficult, as the patient or as the caregiver. And the other person has to stay open to hearing whatever that might be.
Afternoon, everyone. My name is Lloyd Jones. I was diagnosed with limited systemic sclerosis back in 2013. And I have, something to add to the eye condition as well as a question. I've had 4 pterygium surgeries, exterior and interior, on my eyes. And recently my eye doctor has me on Restasis. But he told me that they're not sure of a link between scleroderma and, the problems that come with dry eyes. But he did say that, and don't quote me, but I think he said a third of autoimmune patients are on Restasis. And I can't remember the name of the drug, but it sounded familiar. Plaquenil, I guess it is. I want to know the differences between why you would take Plaquenil versus Restasis.
So they both, I mean, they both work kind of a little bit differently. And so I honestly, like, if you're on something that's working for you, I think that's the most important thing more than anything. And Plaquenil often is started, especially if there's other manifestations of other autoimmune disease, not just the eye. Restasis is super helpful for dry eye symptoms. So if that's the primary thing, I think a lot of times that's the go-to drug. This is also where I recognize I'm a pediatric rheumatologist, and Restasis doesn't have the same FDA approval under the age of 18 because of the way initial trials were set up. We use it all the time, but it's just more of a headache, whereas Plaquenil we can kind of give out like candy. So often Plaquenil in the pediatric world is our first go-to, but certainly, especially if the dry eyes are at a point where it's that severe, then Restasis is a great drug too.
Good to know that they work similarly, because one of the things I'm dealing with now is Restasis has caused quite a few pimples on my face, and then they turn to open sores, and I'm on an immune suppressant, so now I have to deal with these open sores, and so that may be a good option. Thank you.
Amy, could you talk a little bit about the stem cell process pretty quickly? I know it's very involved, but just kind of what you went through. And I know it took about a year for you to really start to feel better.
For my stem cell process, basically that whole process started in 2015. In December, I had to go to Chicago and have about a week's worth of testing done. One, to see if I was a good candidate for the stem cell transplant, and two, to see if I was a good candidate that would actually survive the stem cell transplant. So once it was determined that there was a higher probability that I could survive it, and two, that I would actually have some positive outcomes from it, then I got the go-ahead to get the stem cell transplant. And then, of course, you have to fight with your insurance for a while in regards to getting approval for the stem cell transplant, because, again, it's not standard treatment for scleroderma. It's just a trial that they're trying to figure out if that's another good treatment to help scleroderma patients with. And so by the time I finally got approved, it was around March, and then I had to begin the harvest part of the stem cell transplant, which is another 2.5 to 3 weeks where you have to go back to Chicago. They give you chemotherapy and then give you some drugs that help stimulate the stem cells to get released from the bone marrow. And then you go back about a week later after giving yourself shots that, again, just help stimulate those stem cells to be released. And then they collect them, and then they give you about a month, up to 3 months off to let your body kind of recover from the first treatments of the high doses of chemotherapy. And then you are in the hospital for usually about 3 weeks, getting more high doses of chemotherapy to completely destroy your immune system so that you have no immune system whatsoever. And then after they've determined that your immune system is now at zero, then they'll give you your stem cells back, which normally takes about 5 days of the high doses of chemo. And then that's when it tends to be the most risky time within the stem cell transplant, because, again, you have no immune system, so you're really susceptible to infections and getting sick very easily. Or with a lot of scleroderma patients, we don't handle fluids very well, so they really have to monitor your fluids, because for us, or at least for me personally, we tend to build a lot of fluid on our hearts during chemotherapy, and then people end up having heart failure and also issues with their lungs because of the fluid. So they just keep a real close eye on that. And then it takes, again, about 2 weeks to have your immune system come back to a point where you're about at 1 is what they consider acceptable to be released from the hospital. And it wasn't until about, I'd say, 6 months post-transplant that I started to feel a little bit better. And then in January of this year, I felt a whole lot better, and have slowly progressed in a good direction so that I'm just feeling much better each day. But it's definitely a roller coaster, and you don't know really if it has been successful or not until about 2 years. So I have to keep going back to Chicago and having the full testing completed, first at 6 months, then a year, and then each year after that for 5 years. And so I guess when I go back in May to have my 2-year follow-up, I'll have a better idea of how well this treatment has worked for me.
Amy, this is for you. Did you see Dr. Burt in Chicago?
I did.
Did he ever mention to you what made a good candidate for a transplant?
I think part of the items that made me a good candidate for the transplant, one of the things that they really are trying to stop the progression of with scleroderma is interstitial lung disease. So if you have interstitial lung disease that looks like it's continuing to progress, that makes you a good candidate. Depending on what your skin score is, a lot of people who've had the transplant tend to have a lot of relief when it comes to the skin starting to loosen up. And the other thing that they look at is they're real nervous about giving people the transplant if their heart has been affected too much by the transplant, or by, not from the transplant, but by scleroderma, because what they're finding is a lot of things that they don't look for is stiffening of the heart, which I think just have to have an MRI to really see it. You don't see it necessarily on a CT scan. And that since it's not standard protocol to get your heart checked with an MRI, it's usually through echocardiograms and CT scans. They don't really catch the amount of stiffening that's going on in the heart until you actually start really having symptoms, and at that point, it's there's not a whole lot they can do to correct it.
Can I ask you another question? You and I both know we have the same doc here.
Yes.
So once you have the transplant, and Dr. Burt, I would imagine, manages that portion of your health, do you continue to see the doc that we have in common, and does he basically manage the scleroderma?
I say that Dr. Burt's primary goal or his emphasis is the transplant itself, but your aftercare is done more by your physicians where you live.
Thanks.
Okay, I have a question for, Sandy, were you going to raise your hand? Go ahead.
Dr. Enos, you said you had a patient who had skin softening. Do you know about how long that was after diagnosis, and was it sustainable? Did it stay that way?
Softening sustainable after diagnosis. So are you referring to the patient where I talked about the dietary changes?
Right. Did her skin stay soft, or did it ebb and flow afterward?
I probably saw, for the most part, the trajectory was staying soft, but she did have some ups and downs, but it stayed soft and more flexible.
I have a question for you as well, and it's just curiosity, I guess. The patient that you saw who was in her early 30s who was struggling with infertility after you went through your treatment with her, did she conceive?
So she is putting off conception for a few reasons right now that don't have anything to do with treatment. So she's decided to wait and have some other goals fulfilled before she gets to that place. But I feel very confident with where she is at health-wise that it's going to be no problem for her. She's so much healthier than she was a year and a half ago.
I was hoping there'd be a baby at the end.
Oh, not yet.
Somebody wants to be a grandma again.
Coming from somebody who just became a grandma, and that's all I hear about. Another question for Dr. Enos. You talked about changing diet, but with people in a chronic illness, they're on so many medications that can cause side effects. Do you kind of look at that piece too and see how you can use, change diet or supplements or something to kind of help with the prescription side effects that people have?
Sure. I still use the same base diet because I want to bring down overall inflammation in the body. But depending on certain side effects, I may recommend certain foods or certain nutrients to support the body. So I guess one specific example that I could use is perhaps with long-term use of PPIs, you're going to end up with certain nutrient deficiencies. So I find that mineral supplementation can be very helpful for people on PPIs.
So I have a question for both the doctors here on the end. First, I thought it was interesting that you guys both used a saber-toothed tiger in your presentation to talk about like fear and stress and fight and flight. You both had talked about other types of therapies to kind of work with and mindfulness. Do you recommend or have you used for any of your patients alternative therapies such as acupuncture, craniosacral therapy, one for your patients that you're treating along with their food and diet, but also for that mindfulness piece as well and taking care of yourself and self-care?
Yes, absolutely. I refer people for a lot of other therapies. I do craniosacral myself, and I find that a good way to help people get more in that parasympathetic mode where they can do more repair in the body. So it really helps make that shift for them. And I do refer people for acupuncture, and I also encourage them to cultivate mindfulness in small ways in their life. So even those recommendations that I gave around eating, when you spend that long chewing, you're cultivating some mindfulness around doing that. And I will often check in with people about how they're breathing and see if we can shift their awareness of how they're breathing and put them more in a parasympathetic mode as well. So those are some of the tools that I use.
Yeah, we hadn't met before today, so that saber-toothed tiger thing was unplanned. It just... But yeah, similarly, I'll recommend, I typically will do a self-care plan with patients, and that might sound a little bit silly, but we have to have a plan for everything, and it might include things like mindful eating, take a mindful walk, doing adjunctive therapy, certainly massage, like whatever is going to work for an individual, that's part of that self-care plan. And it does have to be something that can be done, well, you have to have a range, you have to have self-care that can be done like while you're eating a grape, like maybe in 1 minute, and then if you do have the day to go to the spa, then please do that. But we don't always have 8 hours to do that.
When I first got diagnosed, it was probably back in 2000, maybe 7, but I did a couple of things outside the box, which were, I went to my dentist. I had all my silver pulled out of my mouth. My mouth had shrunk. He couldn't even get to the back teeth because I couldn't open my mouth as a result of the changes in your mouth structure. I think there's dental issues that occur as a result of the process too. I noticed a lot of things like food gets stuck inside my mouth easier. It's hard to navigate. Just little things like that people don't talk about. And I did things like foot baths to try to pull out the toxins and the metals out of my body, things that, again, are outside the box, but I was at any desperate degree to try to get my system cleansed or cleaned out or whatever that means.
This is for Dr. Enos. If someone were to become a patient of yours, would you or do you work in conjunction with, as a for instance, my scleroderma doc, or is that pretty much separate? And again, I may be using the wrong terminology, but maybe Western medicine versus a more holistic approach or something like that. But is there a lot of communication, a lot of joint planning, or is it pretty much separate?
Most of the time it occurs pretty separately, and I'm always open to that joint communication, and when that pathway is open and it's needed, I reach out and make it. Not people specialists aren't always open to it, so it's really going to depend on how much both doctors want that communication, and I'm always open to it because I think it's important for continuity of care for patients and for them to get the best care.
Because I learned a lot from your presentation, but the rheumatologist that I have for my scleroderma is a fantastic doc. And so I wouldn't want any type of, adversity back and forth or any kind of conflict. And so just was wondering if how that all kind of played out, the dynamic involved there.
Yes, of course. And I'm never going to tell you, go off your meds, do something that your rheumatologist told you not to do, and I don't want to create any conflict. So I'm doing my best to be complementary care and supportive of the wonderful care that you're already getting. And many times the things that I recommend shouldn't be at conflict with what you're already doing.
Just to speak from the kind of more allopathic or Western traditional standpoint too, I actually have several patients who also see alternative medicine providers and naturopaths, and I completely encourage it. My only thing that I tell these families is, we're trying to fight this disease together. We all have the same end goal, so it's really all about how can we let's attack everything from every possible angle that we can. And I think communication is super important from both ends, that, I'll chat with their other providers and say, hey, these are the meds that I really think are the most kind of crucial in terms of evidence that we really keep on. And then, but what else can we kind of add to the picture? And someone had brought up things like acupuncture that 9 times out of 10, is completely fine. But there are some patients, the issue of calcinosis came up earlier today. If someone's prone to calcinosis, I've actually had patients who went to acupuncture and developed calcium deposits at every single site where the teeny tiny acupuncture needles went. So certain people, that's actually not a great option for. Moxibustion, I had a patient who developed full-blown sepsis after that. And so kind of depending on where people's immune system is, some of these things can be phenomenal adjuncts, and in certain select patients, they may not be the best choice. And so I think for those reasons, communication, and also there's interactions, just because something's natural doesn't mean it doesn't interact with something that's not. And so being sure that, everyone is on the same page, I think is super important. But I think it's a team effort, especially with these illnesses.
I have a question. If you have the injections in your hand for the Raynaud's, how successful are they, and how long do they last?
Like the Botox that Dr. Kolfenbach was talking about. To be honest, in peds, I've never done that, so I have absolutely no experience in answering that. But I can definitely reach out and get an answer to him and kind of funnel it back to the group. But I don't know if anyone here has done it or in the audience.
Go, Gloria.
My question would be digital ulcers. Have either of you had them, and what do you do about them?
I have had them. I had them when I very first was diagnosed. I was a flight attendant at the time, so we had to wash our hands a lot because we're introduced to lots of germs and all that good stuff. And with the Raynaud's and then the constant hand washing and just the lack of circulation, I was getting the ulcers myself. And the rheumatologist that I had been seeing at the time actually prescribed me pentoxifylline, which has helped. And I'm also on Viagra, which has also helped with the blood flow. And I have not had a digital ulcer in, I'd say, at least a year.
I'm ulcer free. In 17 years or whatever, 15, I've never had an ulcer, even though my hands have been white for almost a day straight, which my doctor said she would have had me go to the ER if she knew that. I've been lucky, so yeah.
I was actually pointing to Sandy to maybe respond to that question too.
Dr. Kolfenbach gave a presentation today on the ulcers. Were you in here for that? Okay, and that was recorded, so I wanted to let you know that that'll be available. He gave a couple of different alternatives, but the calcium channel blockers, I think, were the first line of defense, but they don't exactly heal the ulcers. It's more prevention. And the Viagra as well. Topical nitroglycerin was one of the treatments. The Botox, I think, was not exactly in the success column, so they don't do it as often as, it's not a first line of treatment for sure. I'm trying to remember the other ones. He mentioned something about lidocaine injections, but he didn't really elaborate on it. And there is a wound care specialist now at UCH that is in collaboration with the rheumatology team that can help you if you're getting them. And I'm getting ready to go. Got Band-Aids all over my hands, so.
In response to the question about the ulcerating solutions, years ago, back in 06 to about 08, I was given clobetasol, a steroid cream, to help heal that, and it was quite successful.
Anyone else? Going once? Going twice? Okay, well, I'd like to thank our panel today.